Welcome back to the deep dive. Today, we're really diving deep into a pretty complex area, the eye, specifically the uveal tract.
Yeah, we've got a professional medical text here, and we're going to unpack it. Think of it like getting the inside scoop, but making it, understandable.
Exactly. Our goal is to go properly deep, understand the anatomy, what happens when it gets inflamed, look at specific conditions, treatments, the whole picture.
Right. We want you to come away feeling like you've really got a handle on this, almost like you've mastered the source material yourself.
Okay, so first things first, the uveal tract. What exactly is it?
It's basically the middle layer of the eye, sandwiched between the outer coat, the sclera and cornea, and the inner nerve layer, the retina.
And its main job.
Nutrition, essentially.
Yeah.
It's packed with blood vessels.
And it's made up of three parts.
That's right. You've got the iris, the colored part, and the ciliary body, sort of behind the iris, and the choroid, which is the bigger layer at the back.
And you said packed with blood vessels. That sounds important.
Oh, hugely. That's why it's so key for nutrition. But it also means it's a prime spot for systemic diseases to show up. Problems elsewhere in the body can travel through the blood and affect the uvea.
Like a highway bringing issues right to the eye.
You got it. And these three parts, iris, ciliary body, choroid, they're really closely linked. So inflammation in one part, it almost never stays just there.
It tends to spread.
Yeah, the whole uvea often gets involved to some degree.
Okay, let's break down the anatomy a bit more. The iris, ciliary body, choroid. What are their specific roles according to our source?
All right. The iris, well, we know it controls pupil size, but the source highlights its role in the metabolism of the front part of the eye, the anterior segment, helping move nutrients around in the fluid there.
The aqueous humor.
Yeah, exactly. And speaking of aqueous, the ciliary body's main job is making that fluid, the aqueous humor. It nourishes the bits at the front that don't have their own blood supply,
Yeah.
like the cornea and lens.
Got it. Iris for metabolism, ciliary body makes the fluid. What about the choroid at the back?
The choroid's job is nutrition too, but specifically for the outer layers of the retina. Those really important photoreceptor cells rely on it. It's just full of blood vessels feeding them.
So that vascularity is both a vulnerability and essential for its function.
Precisely. It's a double-edged sword, you could say.
Which leads us neatly into inflammation, uveitis.
Uveitis, that's the general term, inflammation of the uveal tract. And like we said, the name itself hints that it often involves the whole thing. If you have iritis, inflammation of the iris.
You probably have some cyclitis, too, inflammation of the ciliary body.
Almost always. So often it's called iridocyclitis. It's very rare for one part to be inflamed in complete isolation.
Makes sense. So how do clinicians classify it? I see the Satian classification mentioned.
Yeah, standardization of uveitis nomenclature. It's based on the main anatomical location. So anterior uveitis involves the iris and ciliary body.
Up front.
Right. Intermediate uveitis affects the middle part, the pars plana, peripheral retina, vitreous base area. Posterior uveitis involves the choroid and retina at the back.
Yeah.
And panoveitis.
All of it.
All of it involved. That's the anatomical way. But the source gives other classifications too.
Like how it behaves over time.
Exactly. Is it acute, sudden onset, short duration, chronic, kind of sneaky onset, lasts a long time, or recurrent, comes back again and again?
And maybe the most important distinction, the pathology, granulomatous versus non-granulomatous.
Yes, this is absolutely fundamental. It tells you about the type of inflammation and gives clues about the cause. Mastering this difference is key.
Okay, let's really get into this. Granulomatous uveitis. What does that look like? Paint us a picture based on the source.
Clinically, you see specific things. Big one. Keratic precipitates, or KPs. These are inflammatory cells stuck on the back of the cornea. In granulomatous cases, they're often described as mutton fat KPs.
Mud and fat, really?
Yeah, it's descriptive. They're large, greasy-looking, whitish deposits. Really distinct.
Okay, mutton fat KPs. What else?
You tend to see dense posterior synechia. That's where the iris gets really firmly stuck to the lens behind it. And nodules, actual inflammatory bumps on the iris itself.
Nodules on the iris.
Gopi nodules are small, right at the edge of the pupil. Busaka nodules are larger, found more out on the iris surface. These are collections of inflammatory cells forming granulomas.
So actual lumps of inflammation.
Exactly. And clinically, this type often starts more gradually, insidiously, and runs a chronic course. The underlying cause is often linked to certain infections, or quite commonly, autoimmune processes involving a specific type of immune response, delayed hypersensitivity.
Okay, so summary. Greasy KPs, dense adhesions, iris nodules, slow onset, chronic, maybe infection or autoimmune. What about non-granulomatous? How's that different?
It's a different beast. The KPs are fine, small, almost dust-like, not the mutton fat type. The onset is usually acute, sudden. Flare-ups tend to be shorter,
But
assuming treatment.
and the inflammation itself.
It's more diffuse, spread out in the anterior chamber fluid. You don't typically see those focal iris nodules. What you do see is a lot of aqueous flare in cells.
Flare in cells, meaning
Flare is protein leaking from blood vessels, making the fluid look hazy, like headlights in fog. Cells are the white blood cells floating around. There can be a lot. Sometimes they settle down at the bottom due to gravity.
and form a hypopion, that visible layer of pus.
Exactly, hypopion. And the cells involved here are mostly lymphocytes and polymorphs. So fine KPs, acute onset, diffuse inflammation, lots of flare in cells, maybe a hypopion that's the non-granulomatous pattern.
They sound quite distinct. Seeing one versus the other must be a huge diagnostic clue.
Absolutely. Recognizing these patterns is step one in figuring out what's going on.
Which brings us to the really tricky part, as the source points out, finding the actual cause, the etiopathogenesis.
Yeah, this is often the toughest challenge. Why is this happening? Sometimes it's obvious, like a clear infection with unique signs, but often it's a puzzle.
And the source emphasizes that even if an infection started it, the uveitis itself might be more about the immune system's reaction later on.
That's a key concept. The body gets sensitized to something, maybe from an infection elsewhere, and the eye reacts later. It's like the eye has these memory cells that overreact when they see that trigger again.
An allergic reaction in the eye to an old enemy.
Sort of, yeah. Or it could be a reaction to bits of damaged eye tissue from inflammation elsewhere in the eye, like a bad corneal ulcer or retinitis.
Let's break down the causes the source lists. Inflammatory causes first, starting with infections from outside exogenous.
Right, like from a penetrating injury, getting poked in the eye, or even after surgery. Or a really nasty corneal ulcer breaking through. These can cause a pretty severe iridocyclitis that can quickly turn into endophthalmitis.
Infection inside the whole eye.
Exactly, or even panophthalmitis, where it spreads to the outer coats too. Really serious.
Okay, then secondary infections.
That spread from nearby tissues like the cornea or sclera getting infected first. And then endogenous infections, these are critical. They come from inside the body.
Via the bloodstream again.
Bacteria like TB, syphilis, gonorrhea, viruses like herpes, mumps, measles, protozoa like toxoplasmosis. And the source really highlights severe bloodstream infections. Septicemia from things like strep, staph, meningococcus can cause a really violent pus-filled panophthalmitis.
Serious stuff. Okay, beyond direct infection, there are the immune-related causes, that hypersensitivity idea.
Very common. Often there was an initial infection somewhere else, body got sensitized, and then the uveitis happens as this sort of delayed immune reaction in the eye.
And then the big one, where the immune system seems to attack the eye's own tissues, autoimmune.
This is a huge category.
Yeah.
Uveitis is frequently linked with systemic autoimmune diseases. The list is long. Rheumatoid arthritis, lupus, SLE, ankylosing spondylitis, sarcoidosis, Behçet syndrome, inflammatory bowel disease, many others.
It's amazing how many body-wide conditions show up in the uvea.
It really drives home that the eye isn't isolated. And genetics plays a role here too, particularly with HLA antigens.
Those immune system markers on our cells.
Yes. HLA-B27 is a famous one, strongly linked with ankylosing spondylitis and acute anterior uveitis. ANA positivity is linked with a chronic uveitis in kids with JCA, HLA-B5 with Behçet's. It suggests some people are genetically predisposed to react this way.
Okay, inflammatory causes covered, but then there are masquerade syndromes. What are those?
These are conditions that look like uveitis, red eye, cells, flare, but they're not actually primary inflammation, they're mimicking it.
What kinds of things can masquerade?
The source focuses mainly on neoplastic causes here, cancers. Things like retinoblastoma in kids, iris melanoma or lymphomas and leukemia spreading to the eye can cause signs that look just like uveitis. It's a crucial diagnostic trap to avoid.
And finally, trauma.
Yep. Getting hit in the eye, a penetrating injury, even just the trauma from eye surgery can cause inflammation. Postoperative uveitis is common, but the big challenge is telling it apart from a post-op infection, endophthalmitis.
Because the infection is much worse.
Way worse. The rule is generally, if in doubt post-op, treat for infection first. You can't afford to miss it.
Makes sense. The source has a useful table summarizing which conditions cause which type: granulomatous, non-granulomatous, acute, chronic. Helps tie it together.
Yeah, that's a great summary. You see patterns like TB, syphilis, sarcoidosis, often causing chronic granulomatous uveitis.
Okay, so we know the parts, the inflammation types, the potential causes. Let's get into the symptoms and signs. What does someone with anterior uveitis experience?
Usually it's pretty uncomfortable. The classic symptoms are photophobia, really bothersome light sensitivity, blurred vision, and pain.
What kind of pain?
Typically a deep aching pain in or around the eye, often feels worse at night, and it can radiate, to the forehead, cheek, even the teeth because it follows the trigeminal nerve distribution. Also, redness, specifically ciliary congestion, right around the edge of the cornea and the eye might be tender to touch.
And what does the doctor see with the slit lamp?
Key signs. Those chorotic precipitates, KPs, on the cornea mutton fat or fine, depending on the type. Aqueous flare and cells, that haziness, and the floating cells in the anterior chamber fluid. The iris itself might look muddy or swollen, losing its fine details.
The color might change.
Yes, especially if you compare it to the other eye. A blue iris might look duller, grayish. In severe cases, you might see that hypopyon layer. Less commonly, a hyphema, which is blood in the anterior chamber.
And this inflammatory gunk, the exudate, causes problems by sticking to things?
Absolutely. It sticks to the back of the cornea, forming KPs. It coats the iris and the pupil. If it's really thick and sticky, it's called plastic iritis. It can form a membrane blocking the pupil, severely reducing vision.
And it makes the iris stick to the lens, posterior synechiae.
Exactly. If they're fresh, strong dilating drops might break them, leaving little pigment spots on the lens. But if they organize with fibrous tissue, they become permanent.
Which makes the pupil look irregular.
Yeah, if you have several spots stuck down, when the pupil tries to dilate, it gets pulled into a scalloped or festooned shape. But the real danger is if the entire pupil margin sticks down.
Annular synechiae, or seclusio pupillae. Why is that so bad?
Because it traps the aqueous humor behind the iris. The fluid's made in the posterior chamber, but it can't get through the blocked pupil to the front. So pressure builds up behind the iris.
Pushing it forward like a balloon. Iris bombay.
Precisely, iris bombay. This makes the drainage angle between the iris and cornea incredibly shallow or even closed off completely, especially peripherally. This leads to peripheral anterior synechial-permanent adhesions in the angle, causing severe secondary angle closure glaucoma. Really difficult to treat.
Wow, and if the exudate is even worse, it can just block the pupil completely.
That's occlusio pupillae, an opaque fibrous membrane right across the pupil. If there's also severe cyclitis, exudates can organize behind the lens too, forming a cyclitic membrane. In kids, this can even look like a tumor, a pseudoglioma.
The end stages sound bleak. Physis bulbi.
Yeah, in severe, chronic, uncontrolled cases, the ciliary body can just give up, stop making fluid. The vitreous liquefies, the lens gets cataractus, and the whole eye just shrinks and becomes non-functional. Physis bulbi, a blind, shrunken eye.
What about eye pressure? It seems it can go up or down.
It's complicated. Often in active anterior uveitis, the pressure rises, hypertensive iridocyclitis, partly due to inflammation messing with drainage, partly the thick fluid itself, and then secondary glaucoma can happen from the synechiae and iris bombay.
But it can also drop.
Paradoxically, yes. If the ciliary body gets badly damaged and atrophies, it stops producing aqueous fluid. Pressure plummets, hypotony, a soft eye. The source calls this an ominous sign, bad news.
Repeated attacks also damage the iris itself.
Definitely. Chronic inflammation leads to iris atrophy. It looks thin, frayed, loses its color and pattern, reacts poorly to light.
And that crucial point about mistaking acute iritis for acute glaucoma.
Yes, worth repeating. They can both present with a painful red eye, but the treatments are opposite. Uveitis needs pupil dilation. Angle closure glaucoma needs constriction. Missing the subtle signs of inflammation, a few KPs, a bit of flare, and treating it as glaucoma by constricting the pupil can be disastrous. You have to look carefully for those inflammatory signs.
Okay, let's focus on cyclitis, ciliary body inflammation.
When the ciliary body is the main player, the exudates get poured right into the vitreous and anterior chamber. KPs are usually very prominent. You see lots of dust or cells floating in the vitreous shell.
And similar nasty consequences from the exudates organizing.
Yes, total posterior synechiae, a cyclitic membrane behind the lens pulling things. Fibrous strands forming in the vitreous can pull on the retina,
causing attractional detachment.
Exactly. And if the ciliary processes get destroyed, fluid production drops, hypotony, potentially physis bulbi again.
Chronic iridocyclitis sounds sneakier.
Often is. Insidious onset. The main symptom is just diminishing vision. Signs can be minimal, maybe mild redness, slight tenderness, a few KPs often settling in that triangular arc pattern at the bottom of the cornea, some vitreous haze. Not the dramatic pain and redness of acute cases.
Just vision slowly getting worse over time.
Pretty much. Iris color change is a late sign, It tends to run a course of flare-ups and quiet periods over many years, gradually causing more damage.
What about hypertensive iridocyclitic crisis? Posner-Schlossman.
This is a specific thing, recurrent attacks of very high eye pressure. But crucially, the eye often looks quite quiet during the attack. Minimal flare, maybe only a few kps that are easy to miss.
So it looks a lot like acute glaucoma, but isn't.
Exactly. It's thought to be inflammation directly affecting the drainage channels, trabeculitis, not angle closure. Finding those few kps is the key to diagnosis, and the treatment is steroids and cycloplegics, not glaucoma meds like pilocarpine. Getting the diagnosis right is vital.
Moving backwards, intermediate uveitis or pars planatus.
This affects the pars plana region, the bit of ciliary body just behind the iris base, and the peripheral retina vitreous. Common in kids and young adults, often bilateral, usually insidious onset.
What are the signs here? Snowballs and snowbanks.
That's the classic description. You see inflammation of the peripheral retinal veins, phlebitis, and characteristic inflammatory exudates near the front edge of the retina, the oris serrata. These can look like clumps, snowballs, in the vitreous base, or form larger confluent masses called snowbanks.
In the front of the eye?
Usually pretty quiet, maybe a little spillover flare and a few kps. The main action is posterior, in the anterior vitreous anterior vitritis. Complications can include macular edema, optic nerve swelling, papillitis, cyclitic membranes, sometimes vitreal bleeding or tractional detachment.
What else could cause that picture?
Need to rule out things like peripheral toxoplasmosis, toxocariasis, syphilis, MS, sarcoidosis. Prognosis varies. Many cases quieten down on their own, but chronic ones can be tough, sometimes needing steroids or immunosuppressants if vision is threatened.
Okay, finally, posterior uveitis, back of the eye. Choroid and retina.
Inflammation of the choroid, the posterior uvea, can be focal patches or diffuse. Since the outer retina gets its food from the choroid, choroiditis always affects the retina too.
Symptoms. Less traumatic than anterior.
Usually, floaters are very common. Decreased vision, but typically painless, unless there's spillover inflammation to the front causing redness and photophobia.
Signs.
Vitritis inflammation in the vitreous gel. You might see the actual inflammatory patches or infiltrates in the choroid retina, swelling, edema, blood vessel sheathing, optic disc swelling, retinal hemorrhages, and late problems like cataract, glaucoma, detachment.
And like anterior uveitis, it can be granulomatous or non-granulomatous.
Yes. Granulomatous choroiditis often suggests direct infection with localized chronic inflammation. Non-granulomatous or exudative choroiditis is more like an acute, diffuse inflammatory response with lots of cells and fluid leakage.
What does a fresh patch look like with the ophthalmoscope?
Typically a yellowish area. It looks deep under the retinal vessels. The choroidal vessels underneath are obscured. The overlying retina looks cloudy or grayish due to fluid seeping through. Edges might be indistinct. And exudates spill into the vitreous.
And as it evolves and heals.
Bruch's membrane, the layer between retina and choroid, can break down, letting more inflammatory stuff into the retina and vitreous. Lots of vitreous haze often means the ciliary bodies involve too panophthalmitis. Healing involves scarring.
Scarring, what does that look like?
The exudate organizes into fibrous tissue, destroying the normal layers, sticking retina and choroid together. The area turns white because the thin scar tissue lets the white sclera show through, and the retinal pigment cells often clump up, especially around the edges, forming irregular black masses. You end up with these sharply defined white scars bordered by black pigment, permanent damage.
And the visual symptoms match this.
In the active phase, vision loss comes from the lesion itself and the vitreous haze. If it's in the macula, vision is hit hard. Distortion metamorphoxia is common, flashes of light photopsia, and seeing a black spot, a positive scotoma.
Positive means you see the spot itself.
Right. Later, the scarred areas are just blind spots, negative scotomata. A central scar means loss of central reading vision. It's often chronic, new lesions pop up, and it frequently affects both eyes eventually.
And posterior uveitis is classified by location, too.
Yeah. Disseminated means scattered spots, often associated with syphilis or unknown cause. Multifocal is fewer spots, often peripheral. Central affects the macula. Juxtapillary, Jensen's, is right next to the optic disc, causing a wedge-shaped field defect.
Okay, given all these possibilities, investigating the cause sounds critical but complex.
It absolutely is. The source stresses tailoring the tests. You don't just order everything. It depends on the history, the exam findings, what type of uveitis it looks like.
But some basics are always done.
Checking pressure, definitely. And a thorough dilated look at the back of the eye, the fundus.
And then specific tests based on suspicion.
Right. For acute anterior uveitis, if you suspect something like ankylosing spondylitis, you might do Sacroiliac X-rays, HLA-B27 typing, inflammation markers like ESR-CRP, suspect sarcoidosis, chest X-ray, ACE level, maybe a Mantoux test, syphilis, serology tests.
Chronic anterior.
For Fuchs' heterochromic uveitis, gonioscopy is useful. For JCA, ANA testing is key.
Posterior uveitis.
If toxoplasmosis looks typical, maybe no test needed, but serology if unsure. For suspected toxocariasis, maybe eosinophil count, IgE levels. Parsonitis often doesn't have useful blood tests for diagnosis itself.
So it's very targeted detective work. ACE, ESR, ANA, HLA, specific clues for specific diseases.
Exactly. Now treatment, what can we do?
For anterior uveitis, the mainstays seem to be cycloplegics and corticosteroids.
Cycloplegics drops like atropine, cyclopentolate, they do a few things. Rest the inflamed muscles inside, reduce the redness and leakiness, and most importantly, dilate the pupil to prevent or break those synechia, the adhesions.
Keep the iris away from the lens.
Precisely. And corticosteroids, the powerful anti-inflammatories. Usually potent topical drops like prednisolone or dexamethasone are the first line for anterior uveitis. As things calm down, maybe switch to less potent ones like fluoromethalone to reduce side effect risk, especially pressure rises.
What if drops aren't enough?
Periocular injection steroids injected around, not into, the eye like methylprednisolone or triamcinolone, gives a stronger local dose, useful for stubborn cases. And systemic steroids pills, or IV, for severe anterior cases or for intermediate or posterior uveitis, they really knock down the inflammation system-wide.
And even stronger stuff, immunosuppressives.
For the really severe chronic vision-threatening cases that don't respond to steroids or need toxic doses, yes. Drugs like methotrexate, cyclosporin, cyclophosphamide, these are heavy hitters, usually managed with a rheumatologist or immunologist involved.
And specific treatment if you find the cause.
Absolutely crucial. If it's TB, you need TB drugs. Syphilis, penicillin. Writers linked to chlamydia, antibiotics, lens-induced uveitis. Remove the lens material. You treat the underlying cause alongside the eye inflammation.
We mentioned the ethambutol risk with TB drugs, vision changes.
Yeah, important to monitor vision and color perception if someone's taking ethambutol. Stop it if problems arise.
Managing complications is also key. Secondary glaucoma.
If pressure goes up due to inflammation or angle blockage, you intensify the steroids and cycloplegics. Add pressure-lowering drops like beta blockers or pills like acetazolamide. Avoid things like pilocarpine or latanoprost, which can worsen inflammation.
And if the pupil gets sealed down, causing iris bombay?
Laser iridotomy is essential. Make a small hole in the iris with a laser to let fluid flow through again, relieving the pressure difference. Best done when inflammation is quieter.
Other complications like cataract, band keratopathy.
Cataracts are common, especially with chronic inflammation or steroid use. Surgery is possible once the eye is quiet. Band keratopathy, calcium on the cornea can be scraped off or lasered. Macular edema needs specific treatment too.
Okay, shifting to a very different, much scarier category. Purulent uveitis, endophthalmitis, and panophthalmitis.
Yes, these are infections inside the eye. Endophthalmitis is mainly infection within the eye's contents, vitreous, anterior chamber. Panophthalmitis is when the infection involves the whole globe and starts spreading outwards into the sclera, episclera.
What causes these awful infections?
Can be exogenous from outside, infected wounds, accidents, surgery complications, severe ulcers. Often starts anteriorly, then spreads. Or endogenous metastatic, spread through the bloodstream from infection elsewhere.
What bugs are usually involved?
Bacteria are common culprits, post-op or post-trauma. Staph, especially epidermidis, strep, Pseudomonas, E. coli, bacillus. Fungi can cause it too, especially after injuries with plant matter or delayed onset after surgery. P. acnes is notorious for delayed post-cataract surgery and endophthalmitis.
And endogenous causes?
Usually from septicemia or in immunosuppressed patients, AIDS, chemo, bacteria, fungi, even viruses. Mucormycosis from the sinuses in diabetics is a specific fungal example.
What are the red flags? How do you know it's this bad?
Sudden severe pain, marked lid swelling, rapid significant vision loss. Especially after surgery or trauma, you have to have a high index of suspicion. Pain and vision loss much worse than expected. Think infection, worsening quickly over just hours, almost certainly infection.
Systemic signs. Fever.
More common with endogenous cases. If you see systemic signs with an exogenous infection, it means it's likely spread outside the eyeball, panophthalmitis, orbital cellulitis, potentially life-threatening cavernous sinus thrombosis.
What does the eye itself look like?
Wound might look yellow, necrotic, often a large hypopyon, severe conjunctival swelling, ecchymosis, intense redness, lids swollen. Vitreous looks purulent, a yellow reflex instead of red. Cornea cloudy, maybe melting. With panophthalmitis, the eye might bulge, hurt to move.
This sounds like an absolute emergency.
It is one of the biggest ocular emergencies. Investigations are urgent, history, exam, ultrasound if you can't see inside. But the crucial step is getting a sample.
A tap from the vitreous.
Yes, vitreous tap or biopsy is key. Immediately send for gram stain, Giemsa stain, and culture on multiple media blood, chocolate, saborate for fungi, thioglycolate for anaerobes. KOH prep for fungi too.
And treatment starts immediately.
Absolutely. Before you even get results, empirical broad-spectrum antibiotics plus corticosteroids usually started right away. Antibiotic choice is critical. Goal is high concentration inside the eye fast. Multiple routes.
How are the antibiotics given?
Intensive topical fortified drops, around the clock. Things like fortified cefazolin or vancomycin plus gentamicin or amikacin. Cycloplegic drops like atropine. Subconjunctival injections are less common now, but the cornerstone is intravitreal injection.
Injecting antibiotics directly into the eye.
Yes, right after the tap. Best way to get high levels. Usually a combination like vancomycin plus ceftazidime to cover gram-positives and negatives. Avoid aminoglycosides like gentamicin amikacin intravitreally, if possible, due to retinal toxicity risk. Intravitreal steroid might be given simultaneously.
What about surgery, vitrectomy?
Yes, removing the infected vitreous pars plana vitrectomy helps clear the infection load and lets antibiotics penetrate better. The EVS study showed it's especially helpful if vision is very poor, light perception or worse, at presentation, or if things aren't improving after 48 hours of intravitreal antibiotics.
And the role of steroids here. Controversial.
A bit. Some advocate using them systemically right from the start with antibiotics, unless fungus is suspected, to reduce the damaging inflammation. Others wait a day or two to see if antibiotics are working. The idea is to save the eye structures from the inflammatory onslaught.
Constant monitoring needed.
Absolutely. Close follow-up, adjusting based on response and culture results when they come back. Visual outcome really depends on how fast treatment started and which bug it is.
If it turns out to be fungal.
Different approach. Intravitreal amphotericin B without steroids. Systemic antifungals. Vitrectomy often needed.
And sometimes the eye just can't be saved. Evisceration.
Sadly, yes. If there's no light perception, signs of panophthalmitis, evisceration, removing the eye contents but leaving the scleral shell, might be necessary to control infection and pain. The source prefers a technique leaving a small scleral frill around the optic nerve to reduce risk of meningitis.
A very serious topic. Okay, let's circle back to specific types of uveitis linked to known causes, going a bit deeper. Bacterial causes first, tuberculosis.
Ocular TB can affect any part of the uvea. It's complex, involving immune cells like T cells and macrophages, plus hypersensitivity.
How does it show up in the front of the eye?
Can be granulomatous uveitis, either small miliary nodules in very ill patients or larger conglomerate masses, or it can be a non-granulomatous exudative type, thought to be more of an allergic reaction, which can be chronic or recurrent.
And in the back, choroiditis.
Acute miliary choroiditis shows up as small yellow spots, often a sign of widespread TB, like meningitis. These can heal with treatment. Chronic forms in large single masses called tuberculomas also occur.
What else looks like ocular TB?
Sarcoidosis, Bissett's, leprosy, syphilis, cat scratch, leptospirosis, brucellosis. The list is long. Need to differentiate.
Diagnosis. Mantoux test.
Mantoux helps, especially if negative in some contexts, but anergy, lack of reaction, can happen. Chest X-ray is vital. Sometimes the trial of TB meds is used. Definitive diagnosis needs finding the actual TB bacteria in eye samples via culture or PCR, which is hard.
Treatment is standard TB drugs.
Yeah, the multi-drug regimen. Rifampicin, isoniazid, ethambutol, pyrazinamide. Remember that ethambutyl eye side effect is important.
Leprosy next.
Eye problems in leprosy are often indirect nerve damage causing exposure problems from facial nerve palsy or corneal numbness from trigeminal nerve damage.
But direct involvement happens too.
Different types of leprosy affect the eye differently. Yes. Lepromatous leprosy often involves the eyelid, with uveitis, corneal clouding, iris atrophy, lots of bacteria present. Tuberculoid leprosy rarely causes uveitis directly. Eye issues are more from nerve damage. Treatment is systemic anti-leprosy drugs.
Spirochaetal, syphilis, the great masquerader.
It really can mimic almost anything, affecting any eye tissue at any stage. Incidence is up, especially with HIV co-infection.
And HIV changes things.
It can make the signs atypical, the course faster, and treatment response may be slower. Always test for both if one is positive. High suspicion needed.
Syphilitic uveitis.
Can be nonspecific, granulomatous, or non-yative.
Yeah.
Often occurs in secondary syphilis. Might see roseola, fleeting, dilated iris vessels. Posterior synechia are common. usually clears with treatment. T. pallidum can be found in the aqueous. Congenital syphilis can cause severe plastic uveitis. And watch out for the Jerisch-Herxheimer reaction, acute flare-up after starting penicillin. Gummatus uveitis is later signed yellowish-red nodules on the iris.
And posterior syphilis.
Hugely variable. Choroiditis chorioretinitis can be disseminated, peripheral, diffuse, look like RP, cause neuroretinitis, optic nerve swelling, vasculitis, vein occlusions, retinal trosis. In HIV, presentations can be unusual, like plaquewood lesions. Botrytis is usually prominent.
Diagnosis relies heavily on blood tests, serology.
Yes, treponemal tests confirm. Crucially, the source states ocular syphilis requires a CSF exam to rule out neurosyphilis because treatment differs. Look for cells protein-positive VDRL in the CSF. Diagnosis can be harder in HIV.
Treatment is penicillin.
Still the drug of choice. Dosing depends on the stage. Ocular syphilis is generally treated like neurosyphilis with high-dose IV penicillin for 14 days due to the risk of co-infection and need for good penetration.
Leptospirosis, another spirochate.
From contaminated water, soil, animal urine, causes flu-like illness. Uveitis happens in up to 10%, sometimes with hypopond. Diagnosed with antibody tests, treated with topical eye meds plus systemic antibiotics like penicillin or doxycycline.
Viral uveitis now.
Various viruses cause posterior inflammation, CMV, herpes simplex, HSV, varicella zoster, VZV, measles, rubella.
Acute retinal necrosis, ARN, and progressive outer retinal necrosis, PORIN, both sound nasty.
They are, both caused by VZV or HSV. ARN is severe inflammation starting peripherally, causing full-thickness necrosis, often leading to detachment. PORIN is seen mainly in immunocompromised patients, like AIDS.
How do they differ?
PORIN starts more posteriorly, affects outer retina first, has less intraocular inflammation, less vitreous flare, but causes faster, more widespread disruption. ARN starts peripheral, progresses somewhat slower, but is still devastating. Both are often bilateral.
Need to rule out other causes of retinal necrosis.
Yes, CMV, toxo, syphilis, Behçet's lymphoma. Diagnosis is often clinical, confirmed with PCR on eye fluids maybe. Treatment is urgent, high-dose 5E cyclovir. Surgery needed for detachments.
Cytomegalovirus, CMV, big issue in AIDS.
Historically, the most common opportunistic infection causing retinitis in AIDS. Looks like white patches with hemorrhages, cottage cheese and ketchup. Heals with atrophy. Can also cause severe retinitis in transplant patients.
Treatment.
Ganciclovir, mainly, often needing long-term maintenance. Heart therapy for HIV dramatically reduced CMV incidence. Ganciclovir implants or intravitreal injections are other options. Infantile CMV, acquired before birth, causes severe systemic problems and eye disease.
AIDS itself mentioned again?
Yes, just noting that unexplained chronic uveitis, non-responsive to steroids in at-risk individuals, should prompt HIV testing. AIDS patients get opportunistic infections and tumors affecting the eye secondarily.
Measles.
Acute measles can cause transient vision issues. The rare late complication is SSPE, subacute sclerosing panencephalitis, a fatal brain retina disease years later caused by a persistent measles virus infection.
Fungal uveitis.
Can be exogenous after injury surgery or endogenous bloodstream spread. Key ones mentioned, candida and histoplasma. Common yeast. Causes opportunistic infections when immunity is down. Hematogenous spread leads to chorioretinitis, often with fluffy white vitreous balls. Treat with systemic antifungals first, then maybe intravitreal antifungals or vitrectomy if needed.
Histoplasma. Causes ocular histoplasmosis syndrome, OHS.
Yes. H. capsulatum is endemic in some areas. In healthy people, it's linked to OHS. Immunocompromised people can get active fungal lesions.
What defines OHS?
The triad. Peripheral histospots, scars, peripapillary atrophy around the optic nerve, and crucially, macular neovascularization, CMVM. Importantly, there are no signs of active inflammation like cells or flare. It's thought scars from past exposure predisposed to CNVM later.
Treatment focuses on the CNVM.
Exactly. If the neovascular membrane threatens central vision, treatment is needed. Used to be laser. Now, standard of care is anti-ZEGF injections into the eye to stop the leaky vessels growing. Active systemic histo needs IV amphotericin B.
Parasitic uveitis, toxoplasmosis first. Very common.
Very common cause of posterior uveitis. From the protozoan Toxoplasma gondii, often linked to cats. Primarily infects the retina, causing retinochoroiditis.
Different in babies versus adults.
Congenital toxo from mother during pregnancy is severe, often affecting brain and causing bilateral macular necrotizing scars. Adult-acquired is typically reactivation of an old cyst, causing a new patch of inflammation next to an old scar with lots of vitritis.
Diagnosis. Treatment.
Serology helps confirm exposure. Treatment for active, vision-threatening lesions is usually a combo of antibiotics like pyrimethamine and sulfadiazine or clindamycin, plus corticosteroids. Crucially, never steroids alone without antibiotics.
Onchocerciasis, river blindness.
Caused by a worm, Onchocerca volvulus, spread by black flies. Microfilaria migrate to the eye. Dead ones cause inflammation. Leads to keratitis, anterior uveitis, sometimes choroidal changes, optic atrophy. Treatment is now primarily ivermectin. Vector control important.
Cysticercosis, tapeworm larva.
Yes, larval stage of Tinea solium. Can end up in the eye, vitreous or subretinal. Live cyst causes a little reaction. Dead cyst releases toxins, violent inflammation, mimicking endophthalmitis. High risk of brain cyst, too, so need head imaging.
Treatment for the eye cyst.
Critical point. No medical treatment. Killing the cyst medically causes severe inflammation and eye loss. Treatment is surgical removal via vitrectomy.
Okay, shifting to immunological uveitis, where the immune system is the main driver. Ankylosing spondylitis.
Chronic spinal arthritis, mainly young men. Strong HLA-B27 link. About 25% get acute recurrent anterior uveitis. Important connection to look for.
Reiter disease, also HLA-B27.
Yes, young males again.
Yeah.
Triad of arthritis, urethritis, conjunctivitis uveitis, often after GI or GU infection, Shigella, chlamydia. Treat underlying infection plus the uveitis conventionally.
Juvenile chronic arthritis, JCA. Uveitis common in kids.
Very, especially certain types. Young girls, ANA plus posturticular JCA, often get chronic bilateral quiet anterior uveitis that can be missed until complications arise. Older boys, HLA-B27 plus P, posturticular JCA, tend to get acute unilateral iritis. Still disease, systemic form less commonly involves the eye.
Payset syndrome. Sounds nasty.
It is. Severe recurrent iridocyclitis, often with hypopyon. Major problem is obliterative retinal vasculitis inflammation shutting down retinal vessels. Part of a systemic disease with oral genital ulcers, skin, joint, neuro issues, strong HLA-B5 link, no specific cure. Treatment is heavy immunosuppression.
Sarcoidosis. Granulomas everywhere.
Systemic disease with non-caseating granulomas. Eye involvement common, often granulomatous iridocyclitis, acute or chronic with iris nodules. Posterior uveitis occurs too. Uveal fever, Hereford's, is a specific presentation. Diagnosis involves finding granulomas on biopsy, supportive tests like chest x-ray, ACE levels, rule out DB fungi.
Vogtkoyanagi-Harada VKH syndrome affects pigmented individuals more.
Yes, Asians, Hispanics, Africans, young adults. Granulomatous panophthalmitis, anterior and posterior, with exudative retinal detachments. Associated with skin hair depigmentation, poliosis, hearing neurological issues, thought to be autoimmune against melanocytes. Treated with long-term high-dose steroids, often immunosuppressants too.
Sympathetic ophthalmitis mentioned earlier, post-trauma autoimmune reaction in the fellow eye.
Correct. A rare but important type.
Heterochromic iridocyclitis of Fuchs, the one with the iris color change.
Yes, the affected iris becomes lighter. It's a low-grade chronic cyclitis. Key signs: heterochromia, few fine KPs, iris atrophy, looks thin, transeliminates. Main complications are cataract, surgery usually okay, and sometimes glaucoma. Cause unknown, maybe nerve-related.
Geographical choroidopathy. Map-like lesions.
Distinct condition, unknown cause. Recurring, well-defined lesions at the RP choriocapillaris level. Bilateral but asynchronous. Adults. Blurred vision if macula involved. Key is no vitreous inflammation. FA shows characteristic patterns of blocking and staining. Chronic course.
Serpiginous choroiditis is related.
Considered a variant. Snake-like spread of inflammation scarring, often from the disc outwards, affects RP choriocapillaris, likely immunological. Treatment is steroids, maybe immunosuppressants if macula threatened.
Acute multifocal placoid pigment epitheliopathy, AMPPE.
Affects healthy young adults, bilateral. Creamy placoid lesions at RPE level. Thought to be inflammatory vasculitis of choriocapillaris, possibly post-viral. Resolves spontaneously, usually with good visual recovery, though RPE changes remain. FA shows characteristic blockage, then staining.
And reminding ourselves about masquerade syndromes again.
Right. Always keep in mind things that look like uveitis but aren't primarily inflammatory, especially tumors, leukemia, lymphoma, melanoma, or ischemia. Need specific tests like cytology if suspected.
Okay. Let's briefly cover vascular and circulatory disturbances.
Uvea is highly vascular. Anterior part has rich connections, so blockages are rare. Choroid has segmental supply, so blockages cause distinct lesions. Massive expulsive hemorrhage is a rare dramatic bleed during surgery.
Central seriatopathy, CSC. Common.
Relatively common, especially young middle-aged males. Fluid leaks under the retina from the RP echoroid, causing blurred central vision distortion. Usually resolves on its own over months. FA shows the leak. Laser is sometimes used for persistent cases, but anti-VEGF, less common here than AMD. Recurrences happen.
Neovascularization of the iris, NVI, rubeosis iridis. Bad sign.
Very bad. Abnormal new blood vessels on the iris, usually from severe retinal ischemia, diabetes, vein occlusion, leads to leakage, fibrosis, and intractable neovascular glaucoma. Treatment is penretinal photocoagulation, PRP, to reduce the ischemic drive, poor prognosis of advanced.
Uveal effusion syndrome, fluid buildup.
Idiopathic fluid collecting between choroid and sclera, causing choroidal retinal detachments. Bilateral. Diagnosis of exclusion. Need to rule out inflammatory hydrostatic causes. Often resolve spontaneously, leading leopard spot RPE changes. Treat underlying cause if found.
Degenerative changes now. Iris first.
Age causes depigmentation, atrophy. Essential iris atrophy is progressive. Unilateral loss of iris tissue, part of ICE syndromes, causes glaucoma. Iridoskis is the splitting of iris layers, often age-related linked to glaucoma. Pigment dispersion syndrome is pigment rubbing off the back of the iris, clogging the drain, causing glaucoma. Krukenberg spindle sample Lacey line.
Choroidal degenerations, more significant.
Often, yes. Can be secondary to inflammation, scars, pigment changes, or primary. Primary includes central atrophy, common in high myopia, aging. Pathological myopia involves extensive myopic crescent, macular atrophy, lacquer cracks, risk of CNVM, detachment, not just stretching, true degeneration.
Essential gyrate, atrophy, metabolic.
Yes, due to ornithine enzyme defect. Causes progressive patchy choroidal RPE atrophy. Choroideremia is similar hereditary degeneration causing night blindness, field loss.
And the big one, age-related macular degeneration, ARMD.
Most common cause of elderly vision loss. Affects macula complex. RPE, brucas, choriocapillaris, photoreceptors. Two types. Dry, drusen, atrophy more common, less severe vision loss usually. And wet, CNVM leaks fluid blood, causes most severe loss.
Wet AMD treatment.
Revolutionized by anti-VEGF injections, bevacizumab, ranibizumab, aflibercept. Slows leakage, preserves improves vision, needs ongoing treatment. End stage is disiform scarring. OCT is key for diagnosis monitoring.
Other senile central degenerations.
T is choroiditis, catatitrusen, central areolar atrophy, large patch of atrophy, limited treatment options.
Choroidal detachment again.
Can happen spontaneously in damaged eyes or commonly post-op if pressure drops too low, causing fluid collection. Dark mass, seen on exam, treat the cause, e.g. fix overfiltering bleb.
Quick run through congenital abnormalities.
Heterochromia, different iris colors. Benign iris nevi, moles. Abnormal pupil position, correctopia or extra holes, polychoria. Aniridia, absent iris leads to glaucoma, cataract. Persistent pupillary membrane, fetal remnants, usually harmless. Coloboma, gap due to incomplete closure of fetal fissure affects iris, choroid, retina, risk of detachment. Albinism, lack of pigment causes poor vision, nystagmus, photophobia.
And miscellaneous. Iris cysts, tumors.
Iris cysts can be simple fluid collections or implantation cysts from trauma surgery, risk of glaucoma. Tumors of the uvea, like melanoma, are a separate major topic, malignant growths requiring specific management.
Right. We have covered an immense amount of ground there, from the basic structure to the complexities of inflammation, infections, immune responses, degenerations.
It's incredibly intricate, isn't it? How much can go wrong in that one middle layer of the eye?
Absolutely. And it really brings home the need for careful examination, understanding those clinical patterns we discussed, and choosing the right investigations, especially with those masquerade syndromes lurking.
Getting the diagnosis right is paramount because the treatments vary so widely, and the potential consequences of getting it wrong or delaying treatment can be severe vision loss, even loss of the eye.
From just blurry vision or floaters to catastrophic infections like endophthalmitis, it really runs the gamut.
And the uvea really does act like a barometer for systemic health sometimes.
Which leads perfectly into our final thought for you. Considering how often issues in the uveal tract, seemingly a localized part of the eye, serve as telltale signs of systemic diseases or complex immune responses originating elsewhere in the body, what does this deep dive ultimately reveal about the intricate and inseparable nature of our overall health? The eye isn't just a visual organ, it's a window, and sometimes a battleground, reflecting the state of the entire system.
A constant reminder that true health is interconnected.